I've spent all morning talking about conditions that cause distress to women. Let's now move stance and talk about sex, something that gives women pleasure, but occasionally can also cause displeasure. So I'm going to talk to you about some strategies on how to deal with these women. And since I'm in the graveyard slot, I'm also going to give you some take-home messages as we go along. Let's start with a case presentation, and this is a true story. I saw this lady about a year ago in my clinic. She's Mrs. A 55-year-old widow who was referred by her GP to me with recurrent urinary tract infection. Now, she had been extensively investigated by consultant urologists, had had negative MSUs, had had cystoscopies, scans, you name it. In front of me was this little woman, pale, who looked frightened, terrified, sad. The kind of patient you get a heart sink feeling with when you see, because you feel you're not going to be able to help her. So I took her history, and towards the end I asked her, bearing in mind that she was a widow, "Are you sexually active?" At which point she started crying. And I thought, oh my God, what have I done? Why did I ask this question? And she said, "Actually, doctor, I'm really pleased you asked me this question. Because since my husband died 3 years ago, about 2 years ago, I started using a vibrator. And I'm frightened that I've actually damaged myself. But since nobody has ever asked me this question, I haven't been able to bring this topic up." So all I did then was examine her and reassured her that everything was fine. Obviously, I also had the other investigations to help me. I didn't make another appointment for her, but I asked her to ring me up and make another appointment if her symptoms came back. A few months later, I got a letter from her saying that she was perfectly okay and thank you for what I had done. So what that demonstrates is that I didn't actually do anything. All I did was ask her the simple question, "Are you sexually active?" And this is something that you can do. It doesn't cost anything. Just 3 simple questions. Are you sexually active? Do you have any problems? And do you get pain during sexual intercourse? Actually gives the patient permission to talk about sexual activity. They will realize that you're not embarrassed to ask this question. And if you're not embarrassed, then they are not embarrassed. So the first take-home message is, don't be afraid to inquire about sexual dysfunction. Because these patients will present to you with hidden agendas. These are their calling cards. They may come with recurrent thrush, vaginal discharge, for which you just cannot find a cause. They could have menstrual disorders, which you cannot treat. Whatever you do not seem to make a difference. They may come for contraceptive advice and HRT advice that you are unable to get to the bottom of because they are not satisfied. Women with cervical smears, those who have abnormal smears, are often frightened that they will have something wrong with their sex or they will actually transmit this problem to their partners, and that is causing sexual dysfunction. We do know that women with incontinence and prolapse have a higher incidence of sexual dysfunction. And quite often, women who have infertility also have sexual problems. And bear in mind that sometimes the infertility is because they are not able to have sex because of the sexual problems. And then you'll have the patient who actually presents to you, the bolder ones, who say, "Doctor, I have problems with loss of desire, orgasm, arousal, and pain." And these patients will present to you as GPs because they feel closer to you. You see them more often, they're familiar to you. And you see them right from childhood to menopause at various stages. Now, sexual dysfunction in females is a very common problem, and we know that about 43% of women in the population suffer from sexual problems. If you look at urogynecological and gynecological clinics, about 50% of women have sexual problems. What about in general practice? Well, this is a large study of 13 GP practices wherein they interviewed a large number of males and females and also scrutinized the notes. And they found that 22% of men and 40% of women received at least one diagnosis of sexual dysfunction. In men, the most common problem was erectile failure or loss of desire, whereas in the female, it was lack or loss of desire and failure to orgasm. 30% of patients said they had actually told the doctor that they had this problem. But on review of the notes, only 3 to 4% had an entry related to sexual problems in the notes. So what does that tell us? Well, that tells us that patients will come to you with sexual dysfunction. And the fact that it was not put in the notes meant that either it was not dealt with because the GPs did not feel adequately trained to deal with it, or they did not think it was important enough. Or time, yeah, that's the other issue. And it is well known that quite often we do not even ask this question because you're frightened to open the box of Pandora because you don't have time, or on the other hand, you're not trained to deal with these problems. So what is sexual dysfunction? Well, sexual dysfunction refers to a difficulty experienced by an individual or a couple during any stage of normal sexual activity. But the question we need to ask ourselves is, when does a less than perfect sex life become sexual dysfunction? Ladies and gentlemen, it's only a problem if it causes personal distress. So for example, if I have sex once a year and it doesn't cause me or my partner a problem, it is not sexual dysfunction. And just by the way, that was just an example. I do it. So take home message 2. A sexual problem needs intervention only if it causes personal distress. And sexual dysfunction can be caused by multiple underlying conditions. It can be anatomical, where it can affect the vulva. It can be prolapse. It can be fibroids, endometriosis. Or it could be that there's nothing physical. There just isn't the chemistry between the two of them anymore. As you can see over here, I don't know how many of you can read this, but he is saying to her, that's not what I meant by being more experimental in the bedroom. And then there can be a psychological underlying problem. We know that women who have physically and sexually been abused have a high incidence of sexual dysfunction. It could be that they just cannot stand their partner. They have an aversion to the partner. I run a postpartum clinic, and I often see women who are absolutely traumatized by childbirth, and this has led to sexual problems. After surgery, both females and males may be frightened to commence sexual intercourse, especially if they have had surgery in the vagina, because they're frightened to cause damage. And you all know that patients with gynecological cancer or breast cancer have a high incidence of sexual dysfunction. And there are other causes. There are chronic medical illnesses or the treatments, various drugs over here that can cause sexual dysfunction. Remember that sex is a psychosomatic activity. It involves the body and the mind, especially in females. And it's not the G-spot that's the most erogenous zone. In females, it's the mind. And the medicine that deals with psychosomatic activity, this psychosomatic activity is known as psychosexual medicine. So it's a mind and body doctoring. So the take-home message 3 is the underlying cause for female sexual dysfunction can be physical and or psychological. So please bear that in mind. So this is the normal female sexual response, which was described by Masters and Johnson, which is linear. It starts off with excitement, plateau, orgasm, and resolution. But this essentially was based on male sexuality and did not take into consideration the various factors that affect female sexuality. It's much more complex. And therefore, a change was suggested. A change was suggested which took into consideration desire. It took into consideration intimacy, which are so important for female sexuality. And therefore, this female sexual circle was suggested and is being used right now. So let's look at this. Well, females are sexually neutral. They do not go around thinking about sex as opposed to men, and I'm not making this up. Men think about sex 5,000 times a year, but they only get it 104 times. Anyway, females are sexually neutral. They seek or are receptive to sexual activity, and under normal or psychological and biological influences which they want, they get sexually aroused. That leads to sexual desire and arousal, emotional and physical satisfaction, and so on and so forth. So let's look at somebody who has inadequate stimulation. That leads to decreased orgasm, decreased arousal, decreased desire, and maybe an unsatisfactory encounter and painful sex, and so on and so forth. That could lead to vaginismus. So how do we evaluate these? Well, females are much more complex than men. So what's the approach to therapy? Well, don't be afraid to ask, as I said earlier. Then you identify the stage and the type of sexual dysfunction. When did it start? Has she already had this problem? Is it a new problem? Did she have this problem with other partners, or is it something new with this partner? Identify the cause for pain, and then tailor the treatment according to the underlying condition. History is very important, and an examination in these women is absolutely important. Because when you do an examination, you'll get a moment of truth. She might actually tell you that she has a sexual problem. And not only can this be diagnostic, but it can be therapeutic as well. Some women just feel that something is abnormal down below. And when you do the examination, you can reassure her, just like I did with my lady, that everything is fine. And that itself could be the treatment. So you take a detailed history, gynecological, obstetrical, and sexual, take a history of medications, any chronic illnesses, and also drug and substance abuse. You do a physical examination, and this is mainly to rule out the treatable causes for pain. And remember that there's no routine laboratory test that you can do for female sexual dysfunction to diagnose this. You can see over here, this lady had been examined, not examined by her GP, and was referred to me with a letter saying that she had dyspareunia. When this lady presented to me, she was absolutely terrified. She thought she was never going to have sex again. What had happened is during childbirth, she had been oversutured. Now, if she had been examined and told that, well, it's a small problem and it can be sorted, by the time she got to me, she wouldn't have been such a nervous wreck. Because all I did was examine her and under local anesthetic divided that. And she was absolutely delighted after that. So take home message 4. Physical examination in women with sexual difficulties can be diagnostic as well as therapeutic. And there is really no routine laboratory test that you can do in these women. So management includes counseling about abnormal smears, infertility, if these are conditions that they have, treating the underlying cause, which could be incontinence, prolapse, endometriosis, and then condition-specific treatment depending upon the type of sexual dysfunction. Now remember that how you treat this young lady of 35 years old who has loss of libido and has various other problems, which are financial, the need for wanting another child, and also has been sexually abused, is totally different from this lady who's 64 years old, is menopausal, but is happily married, has had no problems with her sex life, but has more recently started getting pain during sexual intercourse and loss of libido. Totally different treatment. The first lady needs help, maybe most even psychosexual counseling, whereas there may be some things that you can do for this lady. Now, because of Viagra, we are seeing more and more elderly women asking for help with their sex life. So what would you do for this patient of mine? Well, first of all, you find out whether she's got vaginal dryness, and you could use vaginal moisturizers such as repellents. If there is evidence of vaginal atrophy, you could use local estrogens. And in some of them, you could use systemic estrogens, although having said that, that is not an indication, sexual dysfunction is not an indication for systemic estrogens. It could be helpful for the vasomotor symptoms which could be affecting sexuality. So in this patient, I would make sure that there are no psychosexual issues. Review HRT if she's on it. You may want to start it if she has vasomotor symptoms. If she is on estrogen, on HRT, you may want to actually increase the dose. Consider using tibolone, especially if she's been amenorrheic for more than a year, because it does have androgenic effects, and there is some evidence that it can it can help with sexual dysfunction or loss of libido. What about testosterone? Well, just recently, 2 forms of testosterone that were available, the implant and the patch, has been withdrawn, and this is mainly because of commercial reasons, not because of any side effects or anything like that. So what we have right now is just the estrogen gel, which is not licensed for use in female sexual dysfunction. So you could use that gel as an unlicensed medication if the symptoms indicate that this is needed. But bear in mind again that this is unlicensed. So the take-home message 6 is tailor your treatment according to the patient's need. So when should you refer your patients for psychosexual counseling? Well, after you reach a level of comfort. When you're sure there's a psychosexual problem and you cannot find an organic cause. But most important, when you refer your patients for psychosexual counseling, you need to be sure that the patient actually wants this and accepts treatment, because otherwise they'll not end up going to the psychosexual counselor. They'll just tell you that they're going to go and they won't go. And it's also important to tell them that you're not actually referring them for psychiatric treatment, you're referring them to somebody who could help them with their sexual problems. So the take-home message 7 is consider referral for psychosexual counseling when you think it is necessary. Ladies and gentlemen, just as people's view on global warming is changing, people's view on sexuality is also changing, and I think the time has now come for us to equip ourselves, get training to deal with women with sexual dysfunction. And I'll finally end with my last take-home message, which is a quote by Socrates, which I think applies to women with female sexual dysfunction. And this, he said, is the reason why the cure for many diseases is unknown to the physicians of Hellas, because they disregard the whole, which ought to be studied too. For part can never be well unless the whole is well. Thank you very much.